Good evening, everyone. Welcome to today's class. And we're going to continue from where we stopped. Remember, we have not begun the core content of the ECG class. We are just trying to bring ourselves up to speed by brushing through some Nclex styled questions. So again, this is just an ECG quiz review class. We are yet to start the core content. And I assume this is where we stopped last week or a few days back. So let's continue from where we stopped. Let's look at the next question. A client at 32 weeks gestation goes into cardiac arrest. What is the nurse's best action while performing cardiopulmonary resuscitation for this client? Again, we've always mentioned on the course how you want to take care and focus on the information the Nclex is trying to tell you. So why are they telling us this client is pregnant? Is there a reason why they have thrown this into the question? And again, they're asking us for what the nurse's best action would be while performing CPR on this client. Let's look at the option. But before that, we want to remind ourselves, what are the common causes of sudden cardiac arrest in pregnant clients? One of them would be obvious embolism. They could also go into eclampsia, and that could also cause sudden cardiac arrest. You can also see sudden cardiac arrest in our pregnant females when they have cases like magnesium overdoses or even uterine rupture. But if we're going to carry out CPR on this kind of clients, it's important that we make some little modifications. Okay, so just 1 minute. I don't want someone sharing my screen with me, so I'm just going to take off the whiteboard. So let me quickly do that. Okay, so you can remember that when someone is pregnant, the heart is going to be displaced towards the left because the growing uterus is going to be pushing upward on the diaphragm, especially in the third trimester. So for us to accommodate this displacement, you want your hands to be placed on the sternum slightly higher than where we would normally place the heels of our hands. So again, we said that during pregnancy, the heart is usually displaced towards the left as the uterus continues to grow. So because of that, we want to accommodate that displacement. We want to place our hands slightly higher than usual. Also, what you also want to remember for the Nclex is that gravid uterus can significantly compress the client's vena cava. It can compress the aorta, and that's going to hinder effective blood flow if we are doing CPR. So another modification you must know for the Nclex, especially with clients who are pregnant, is that you want to displace the uterus manually to the client's left side. This is going to help to relieve that pressure on the vena cava and on the aorta. So again, the first one we said was that we want to place, normally, where do we place the heels of our hands? We place the heels of our hands on the lower half of the sternum. But again, we said with a pregnant female, because we know that the heart is displaced to the left as the uterus is pushing on the diaphragm, we would now need to place our hands slightly higher than usual when we're carrying out chest compressions for these kind of patients. And secondly, we said the gravid uterus is going to be pressing on the vena cava, is going to be pressing on the aorta, and that's going to reduce blood supply during CPR. So we want to manually displace the uterus to the client's left side. So how can you do that? We can take like a wedge or maybe a pillow. So you can look at the diagram there, and you can see how they've used that to kind of tilt the female to the left side. So again, we want to place our hands slightly higher than where we would normally place the heels of our hands. So you can remember option A, compress the chest at the second intercostal space, right sternal border. That would be a wrong option action. Option 2, perform chest compression slightly higher on the sternum. So I'm going to hold on to this. Again, with the Nclex, don't just, maybe as you are reading through the answer, option A is wrong, wrong. Option B is correct. You just pick option B and go to the next question. No. You know, these guys, they take their time to, they have these guys that sit around compiling and writing all of these questions. They try to make it a little bit tricky. So don't just look at an answer that seems right and wrong with it. You always want to evaluate all of the answer choices on the Nclex and then make your selection before you move over. So even though option B looks correct to me, I'm not just going to tick it and take off. No, I'm going to look at the remaining other option choices. So option C says, place hands just below the diaphragm, perform chest compressions. So that would also be wrong. Option D says, position the client in the supine position for optimal compression. That would not be, and again, always look at your whatever answer you choose on the Nclex must address your topic. Whatever answer you choose on the Nclex must address your topic. So again, look at number 4. In the supine position, we already said the uterus is going to press down on the vena cava and the aorta. So that doesn't address my topic. My topic being that pregnant female at 32 weeks gestation. Again, that's like the third semester, so trimester, sorry. So again, whatever answer you end up with on the Nclex, it must address your topic. That's why you must, first of all, even though we're not actually doing that now, but on your test day, you always want to make sure you use the 5 steps of the decision tree because you must know what your topic is. And in your final step in step 5 must address the topic. That even when you come out of the hall that day, you're going to be sure that, yes, I'm sure I did well on this test because for every question on the Nclex, I was able to identify my topic. And in step 5, which is my evaluation, when I evaluated the answer choice I selected against my topic, it addressed the topic very well. That's always going to be your correct answer. So option B is going to be our correct answer. So I'm going to try, we may go past the 1 hour mark this night because I want us to complete, let's get through with all of this quiz so that we can now go back to attend to our core content class on the ECG. Okay. The nurse is supervising a graduate nurse on a telemetry unit. An assigned client develops asystole with no pulse, and emergency care interventions are initiated. Which action by the graduate nurse will cause the supervising nurse to intervene? So they're asking us to pick something that is wrong, an action that is wrong. Again, they've already told us this client is in asystole. He doesn't have a pulse. Well, he's in asystole. I wouldn't expect him to have a pulse. But again, they've given us that information, our client in asystole. Remember when on the first day, what did we talk about? We said the ECG records electrical activities of the heart. And if the ECG is not detecting any electrical activity, it's going to tell you this patient is in asystolic state. A is a prefix for absent. Systole means contraction. Remember, it is that electrical activity that is happening in the heart that translates to mechanical contraction of the heart. So it's telling you there's no contraction. And why is there no contraction? Because I'm not seeing any electrical activity in the heart. So obviously, our client is not going to have a pulse. And what's going to happen on your ECG graph? The ECG needle is going to remain on the isoelectric line. So you're going to have what we refer to as a flat line. Again, what do we need to do for clients in asystole? On day 1, we talked about those non-shockable rhythms. And like I mentioned, I told you the Nclex doesn't expect you to be a consultant cardiologist. They know you're an entry-level nurse, and they just expect you to know those basic ECG rhythms. For example, you should know that asystole is a non-shockable rhythm. Asystole is a non-shockable rhythm. What other non-shockable rhythms do we have? Remember, we mentioned 2 rhythms. Please, if you've not watched the previous videos, you want to go back and watch the previous 2 days of the quiz that we covered. The thing is, repetition. With repetition comes assimilation. If you keep listening to those videos, if you keep listening, you would even hear that I keep repeating same thoughts over and over again, because when you keep hearing it and hearing it over and over again, you tend to retain it better. So again, our non-shockable rhythms would be asystole, and the second one would be pulseless electrical activity. So again, what's happening with pulseless electrical activity? So pulseless electrical activity, like we mentioned on the first day, would be any organized rhythm that is not generating a palpable pulse. So again, you look on the ECG monitor or your patient monitor, you are seeing an organized rhythm. But again, when you try to feel for a carotid pulse or maybe a femoral pulse or whatever, you do not get any pulse on the patient. So that would be called a pulseless electrical activity. But again, there's an exception to that. So let me redefine it again. Pulseless electrical activity would be any organized rhythm that is not giving you a pulse except ventricular tachycardia. So again, you want to add that final notes. So pulseless electrical activity is any organized rhythm that is not generating a pulse except ventricular tachycardia. I'll break it down subsequently when we talk about ventricular tachycardias, but I just want you to remember this, that there are two non-shockable rhythms. You must know this for the Nclex. There are two non-shockable rhythms. One of them would be your asystole, and the second of them would be your pulseless electrical activity. And we said pulseless electrical activity, any organized rhythm that is not generating a palpable pulse. Okay, so with even what I've discussed so far, option 4 would be our correct answer, because we know that asystole is a non-shockable rhythm. So it will not be wrong for the graduate nurse to give epinephrine. Yes, we want to give epinephrine when we are resuscitating a patient in asystole. Yes, we want to give oxygen when we're using our BVM or our bag valve max or your bag max. So number 2 would be a good action. We don't need to intervene. Number 3, yes, this patient is in a cardiac arrest state. We want to initiate chest compressions. Remember, we're going to be giving 30 compressions and 2 breaths. 30 compressions, 2 breaths, and then we reassess and see if the rhythm has changed. And then we can put in our epinephrine and all of that. But again, we don't want to shock these patients in option 4. So option 4 would be your correct answer. We need to intervene because asystole is a non-shockable rhythm. A 2-year-old at an outpatient clinic stops breathing and does not have a pulse. CPR is initiated. When the AED arrives, the nurse notes that it has only adult AED pads. What is the appropriate action at this time? So what's an AED? An AED is an automated external defibrillator. And remember, the earlier you use your AED, the better the patient's prognosis. So yes, I know we talked about doing 30 compressions, 2 breath, 30 compressions, 2 breath for 5 cycles, but we need to shut that down if we can get our AED on spot. So immediately we get our AED, you are attaching the pads, or well, first of all, you want to turn it on. So that's the first thing you want to do when you get your AED. So you want to remember that the first step when you are using your AED is to turn it on, because it is automated, meaning it's going to tell you what you need to do. And the only way you will know the first step is when you turn it on, and then it tells you, go ahead and do this, go ahead and do this. So you want to, first of all, turn the AED on. It's going to tell you to attach the pad. It's going to tell you to stay clear. It's going to tell you to press the shock button. So again, with AEDs, you want to remember, so some major considerations we need to know for the Nclex as regards AED use is, one would be, if your patient has let me say, medicine patch or maybe a pacemaker that's inserted into the patient, you don't want to place your AED pads over a medicine patch or over a pacemaker. That's one major consideration you want to know. So again, we can just move away from where you have the medicine patch and place our pads. Or you can take off the medicine patch and clean the area and apply your pads. But if you have an inserted pacemaker, you don't want to put your pads directly over the pacemaker. We can just move to the side and then attach our pads. One other thing else you need to know is if the patient is hairy, like there are some guys who have like so much hairs on their chest. If you try to attach the pads, it's not going to adhere as it should. So that's why it's advocated that you want to have your shaving stick, and we can shave the area quickly and attach the pads, and it will adhere better. Another major consideration you want to know as regards the Nclex in terms of our AED pads would be if the patient has been submerged in water, maybe somebody can drown or near drowning and the person goes into arrest. You don't want to attach the pads with all of the water on the chest. So you want to dry the chest, mop up all of the water, and then you want to attach the pad. Again, another thing you also want to know would be when do we use adult pads and when do we use pediatric AED pads? Even though I don't have a picture of it here. So you can either use a pediatric AED pad or one that has an attenuator. So what's an attenuator? You will see it as an extra addition on the pad. So there's this little box that's hanging on the pads. So what that does is that it tries to step down current from the AED. So again, we want to use a pediatric AED pad or one that has a dose attenuator for children 8 years and below. So again, pediatric AED pads or pediatric dose attenuators should be used for children age birth to 8 years if available. And standard adult pads can be used as long as they do not overlap or touch. So again, because the adult pads are bigger, you want to try to avoid them touching or overlapping. So if we're going to use an adult AED pad, then we could place one on the chest and the other on the back. So again, option 2 is going to be our correct option. So you want to avoid them overlapping. So for children less than 8 years, you want to use the anterior posterior pad placement. But for children greater than 8 years, we can use the anterolateral pad placement. So this is your anterior pad, and this is your lateral pad. And always remember, the one on the right of the sternum and below the clavicle should be on the right side, while the lower one should be on the left side. Again, you can see this on the Nclex. They try to confuse you and put the upper one here and put the lower one here. So again, this would not be the correct placement. You want to have one under the right of the sternum and below the clavicle, and the other one to the left of the cardiac axis. So option 2 would be our correct answer. Okay, so it seems like we're having more of resuscitation cardiac cases, but again, it's still fine. It's still part of the ECG curriculum. So the charge nurse responds to a cardiac arrest with resuscitation in progress of an adult client. Which of the following actions by a resuscitation team member would cause the charge nurse to intervene? So again, we're looking for something wrong. We already talked about chest compression or CPR. So again, CPR will be cardiopulmonary resuscitation. So I want you to write down these numbers because they are very important when we talk about chest compressions. So again, when we are carrying out chest compressions for an adult, our rate should be between 100 to 120 per minute. Again, that's an Nclex question right there. You want to ensure that your rates are between 100 to 120 beats per minute. And we want to ensure our depths are 5 inches or 2 cm. Sorry, 2 inches or 5 cm. Sorry, I turned it the other way around. So again, your compression rate should be between 100 to 120. and our depth should be 5 cm or 2 inches. Again, you always want to allow for complete chest recoil before compressions. So again, what we mean by allowing for chest recoil, you don't want to press down on the chest without allowing it to go back to its natural position. So you want to compress down on the chest, allow it to come back up to the natural state before you press down on it. So we said 100 to 120 beats per minute. That's our rate. And we said our depth would be compressed at least 2 inches or 5 cm. And then we want to give 30 compressions followed by 2 breaths. So again, they're asking us what would cause the nurse to intervene. Let's look at option 1. Chest compressions are performed at a rate of 100 to 120 per minute. That is very good. That's where we want our compressions to be. Again, you're wondering, how can I know what my rates are? The AHA has introduced audiovisual devices. So you can go on, maybe after the class, you can go on Google Play Store and download a metronome. So a metronome is like an app that would help to keep you at a certain compression rate that you choose. So look at the app and you will see you can adjust the rate. So again, for example, since we have been told we want to be at 100 to 120 per minute, we can increase the rate to be at least 110. And then the metronome gives you that audio prompt. So you hear something like boom, 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 boom. So in as much as you are following that beat, it means you are giving those compressions at that specific rate that you have set. You can increase it to 120. All you need to do is to follow that beat, and you're going to maintain that rate, and it's going to be within the required rates of 100 to 120. Let's look at option 2. Defibrillator pads are applied at the left and right sternal borders. So again, so that's our sternum there. Now they're telling us that the pads are applied at the left. So this would be the left, and this would be the right sternal border. So this would be wrong pad placement. Already talked about where we want our pads to be. One under the right of the sternum, below the clavicle, and the other one to the left. So option 2 is going to cause me to intervene. But again, I'm not just going to pick it and run with it. I'm always going to make sure I evaluate the remaining options. Look at number 3. Manual breaths are delivered at a rate of 2 breaths per 30 chest compressions. So again, is that going to cause me to intervene? No, because we already talked about it. We said we're going to give 30 compressions followed by 2 breaths manually. And number 4, resuscitation team is alerted to remain clear of client before defibrillation. Okay, so probably didn't mention it earlier, but again, when you want to press the shock button on the AED, you want to make sure everybody's clear of the patient. So I want to hear you shout it out. Everybody stay clear, and then you make sure everybody's clear and you press the shocking button. So I'm not going to intervene in question, not in option number 4. So option 2 would be our correct answer. Here we have a client with dilated cardiomyopathy who has this rhythm. So good enough is already written there that this is a ventricular tachycardia. And they're asking which action should the nurse take first. So again, I want you to write this down as regards ventricular tachycardia. So your client can come in with a VT or a ventricular tachycardia, and the route of management is going to be based on the patient's presentation. So I'm not just going to see a ventricular tachycardia on the monitor and I'm going to take action. I'm going to do what I've been trained to do. I'm going to do what every nurse has been trained to do, which is to carry out what? Assessment. Again, remember, you are treating the patient, not the monitor. You are treating the patient, not the lab values. You want to focus on the patient. So again, if I come and my ventilator alarm is going off, I'm not just going to run to the alarm and start working on it. I want to assess my patient first. If I go to my patient's bedside and I look at the cardiac monitor and I see asystole, I'm not going to say, this man is dead. No, I'm going to do what every nurse has been trained to do, which is what the Nclex expects you to do. At least in, how am I going to put it? If, in as much as my patient is not in distress, I want to initially assess. Yes, I know I'm seeing a ventricular tachycardia, But I know that this patient can present in two ways. He could either present with a ventricular tachycardia and he doesn't have a pulse, or he can present with a ventricular tachycardia and he has a pulse. Because if he presents in a ventricular tachycardia and he has a pulse, the management differs. So again, so I'm going to say here he has a pulse and here he doesn't have a pulse. So even if he has a pulse, my management is also going to, I can break it into two. And I'm going to ask myself, is this patient stable or is he unstable? Again, that's also going to determine how I manage this VT. So again, the first thing is, yes, he's coming in a ventricular tachycardia. He has a history of dilated cardiomyopathy. That's fine. But again, does this patient have a pulse? And I'm even looking at option one, and it says assess the client for a pulse. That's going to be my first option choice, because I know that however I'm going to treat this patient is going to be dependent on if he has a pulse and he doesn't have, or if he has a pulse or if he doesn't have a pulse. Because if he doesn't have a pulse, which is this, so if he doesn't have a pulse here, what am I going to do? It becomes an emergency, because now this patient is in a cardiac arrest state just by virtue of not having a pulse, because this is no longer a ventricular tachycardia. This has become a pulseless ventricular tachycardia. It has become a pulseless ventricular tachycardia. And what do you do for patients that are in a pulseless ventricular tachycardia? You shock the hell out of them. So you can remember we've mentioned two non-shockable rhythms, and now we're talking about one shockable rhythm. Again, we said asystole is a non-shockable rhythm. We said pulseless electrical activity is a non-shockable rhythm. Now we're talking about shockable rhythms. And we said if we have our client in ventricular tachycardia, we want to assess if he has a pulse or if he doesn't have a pulse. Because if he doesn't have a pulse, it means he's in a pulseless ventricular tachycardia, and that's a shockable rhythm, and we're going to shock the hell out of this patient. So for pulseless ventricular tachycardia, our line of management would be to do what? Carry out defibrillation of this patient. You need to carry out immediate defibrillation of the patient in a pulseless ventricular tachycardia. But either way, you can see how assessing the patient to determine if he has a pulse is already our correct option. But again, I'm going to look at option two. Option two says assess the oxygen saturation. Again, I mentioned to you, does the answer address your topic? Because some people are going to look at this and say, it's an ABC option. It's breathing, it's oxygenation, it's circulation. No. Is this your patient's problem at this point? Does this address the topic about our clients being in a pulseless ventricular tachycardia? Because now we don't even know if he has a pulse of it. Or how about he doesn't have a pulse? Would giving him oxygen solve his problem? It won't, because he's in a cardiac arrest state. That would not be your priority. Your priority would be to shock the hell out of this patient because he's in a cardiac arrest state. That's if he doesn't have a pulse. But the only way we can know if he has a pulse or if he doesn't have a pulse is when we assess for a pulse. Again, that's the first step in your nursing care process. So I keep repeating it. Most of these Nclex questions are not real questions, because if you use only the decision tree, you kind of rule out wrong option choices, and the answers are staring you in the face. Because for this, even if I didn't know what this rhythm was, but I see that I want to assess for assessment, that assessing for a pulse, that would be my priority. Again, it addresses my topic with this client being in a ventricular tachycardia, because I want to know if he has a pulse or not. How about option 3? They are telling us initiate cardiopulmonary resuscitation. Again, we need to know, because ventricular tachycardia is not a cardiac arrest state. You only want to initiate cardiopulmonary resuscitation in clients who are in cardiac arrest. But the only way we can know if this client is in a cardiac arrest is if we do number 1, which is to assess the client for a pulse. So option 3 would be a wrong answer. Again, prepare to defibrillate this client. Would that be my first action? Remember, they're asking us which action you will take first. I'm not going to prepare to defibrillate this client in ventricular tachycardia because I don't even know if he's pulseless or not. So again, option 1 is still my best option. So again, with VTs, you want to determine if the client has a pulse or not. If he doesn't have a pulse, you want to shock the hell out of the patient. But if he has a pulse, you're going to ask yourself, is this client stable or unstable? And then we can carry out all those vagal maneuvers and all of our using of adenosine and carotid sinus massages and all of that. But we'll talk about that on the live course. But again, it's just nice that we'll bring it in here so that when we hear it again, it kind of sticks. A client with palpitation is admitted with supraventricular tachycardia. So the client is admitted with supraventricular tachycardia. The client's heart rate is 210 per minute. Again, I won't be surprised. They've already told us it's tachycardic, so if the heart rate is above 210, that would be expected. Now they're asking us what is the most appropriate initial intervention. So again, just like we said with this client in a ventricular tachycardia, now we have a client in SVT, or what we refer to as supraventricular tachycardia. So again, we know he's admitted with this. Obviously, he will have a pulse because they've told us the heart rate is 210. So we won't need to start assessing for a pulse. We already know he has a pulse. The heart rate is 210. But again, most supraventricular tachycardias are usually treated with vagal maneuvers. So again, even like with our client with ventricular tachycardia, if the client was stable, if he had a pulse and he was stable, we can attempt to treat him with a vagal maneuver. You know, one example of your vagal maneuver would be asking the client to bear down as if they are having a bowel movement. So this would be your Valsalva maneuver. Again, you might need to attempt it frequently to see if it can help to slow the heart rate down. Remember, these vagal maneuvers, they work by increasing intrathoracic pressure. And they also they work by stimulating the vagus nerve. Remember, it's the vagus nerve which supplies those parasympathetic nerve fibers to the heart. And it's going to result in slowed electrical conduction through the AV node. And that's going to help to slow down the heart rate. So again, I'm already liking option 1. So I'm going to hold on to it. And I'm going to go look at the other option. Look at option 2. It says grab the crash cart and apply hands-free defibrillation pads. Again, you want to remember, okay, so we said, since we don't have any information on this question that this client is unstable, normally we're going to treat SVTs with our vagal maneuvers. But if this client was unstable, so if he was unstable, the best line of action would be to carry out cardioversion. We talked about this on the first day of the course, where we said for unstable tachycardias, you want to carry out synchronized cardioversion. So if you've not watched the previous videos, you want to go back and review synchronized cardioversion. So we're not going to be defibrillating this patient. Remember, we said defibrillation would be for clients in cardiac arrest. This client is not in a cardiac arrest. His heart rate is fast. So we would not be carrying out defibrillation. So option 2 is going to be wrong. How about option 3? Place ECG leads on the client to further assess electrical activity. So again, our most appropriate initial intervention for this client would be to slow down the heart rate. So most times on the Nclex, people are confused. Most people see an assessment on the question and then they feel like, okay, since they've already given us an assessment answer, I don't need to assess, I need to implement. So again, you always want to validate that assessment data has been given to you. Because if I'm not able to decide on my next line of action or what intervention I should do, then it will be wrong for me to just carry out any intervention without assessing further. So again, here, I don't think I need to assess further because they've already told me the client is in SVT. And I already have some parameters to work with here, 210 per minute. You don't need to assess further. If they have told me, I don't know what example I can give now, but for example, someone comes into your office and says they are bleeding. You're not going to just start doing something. You would like to know. So if the patient tells you I'm bleeding, that's an assessment they've given you in the question. But that is not enough because now I don't know where you are bleeding from. I don't know, were you shot? Were you stabbed? I need to know, is it an arterial bleed? Is it a venous bleed? Again, I need to assess for that in that kind of situation because it's going to help me to determine what I need to do next. So you're not going to come in and tell me you're bleeding and I start bandaging you from head to toe. No, I would like to assess for that. So that's how I want you to look at the Nclex. Ask yourself, do I have enough assessment data? Or do I need to validate the assessment data that has been given to me? Or do I need to assess for that? That's going to help you to decide what the right option should be. Because if I have an assessment data that is not enough, I need to assess for that. So I know that my answer would be another assessment option. But if I have enough assessment data to work with, then I know I'm looking for an implementation answer. So that's how I want you to look at the Nclex. So again, in option three will be wrong. I don't need to assess further. And with option 4, place an IV line distally from the heart for adenosine administration. So again, most times you can see that almost all of these questions we are working with, they are all intertwined, right from the first day of the class, even to the second day. There's no other place they can create questions from other than from all of this we have been talking about. We've talked about adenosine on the first day. We talked about adenosine on the second day. We're talking about adenosine again. So remember again, last time we said we can use adenosine to slow down the heart rate, but we said you want to give it fast because it has 5 to 6 seconds half-life. So before you know it, it's broken down in the body. And if we are placing a line to give adenosine, we want to place it as close as possible to the heart so that it can have that full therapeutic effect. So we said it has a very short half-life. You want to give it over 1 to 2 seconds. And we said every time you give adenosine, you want to follow it with a 10 to 20 mils of normal saline flush. Remember, we talked about that when you give adenosine, what are you going to see? You're going to see this transient asystole. So we said you're going to see this transient asystole. So again, you can expect to see this on the Nclex. That once, okay, so you see here, adenosine has been given. What do you see? Almost like the patient has flatlined here. But after which, what happens? The rhythm returns to a normal sinus rhythm. So you can use chemical conversion, like using our adenosine, to convert that very fast heart rate to a normal sinus rhythm. Again, we said if the patient is unstable, we want to carry out cardioversion, and we can use that to convert that rhythm. Or if the patient was stable, we can use all of our vagal maneuvers like your Valsalva maneuver, asking them to bear down, asking them to push on blow on a straw, putting cold compress on the forehead of an infant and all of that. So again, option 1 would be our correct option because we can use this to slow down the heart rate. So this makes this wrong. We don't want to put the IV line distal from the heart. Rather, we want to put it as close to the heart as possible. The nurse is caring for a client with an implantable cardioverter defibrillator. The client goes into ventricular tachycardia and is pulseless. The ICD has fired twice. What action should the nurse take? So it tells us this client has a defibrillator implanted and he goes into ventricular tachycardia. So again, like I told you, there's no other place they can bring questions. They are just running around the same question. So this is still that same VT and the patient is pulseless. Remember, if it's VT and it has a pulse, it is just your regular VT. But if it's pulseless, it means the patient has gone into cardiac arrest because pulseless VT or your PVT is a shockable rhythm, is a cardiac arrest rhythm. So what do we want to do for this patient? We want to start CPR, we want to get a manual defibrillator, we want to shock this patient, and we want to give our epinephrine and all of that. So again, let's look at the option. They're asking us which action would the nurse take? So now they've told us that he's in ventricular tachycardia and his pulseless. It means there's no cardiac output. The heart has stopped beating. So what do you want to do for these patients? We want to initiate chest compression. That would be my priority. We need to initiate chest compression to provide circulation of blood to vital organs. So again, we want to administer epinephrine, 1 milligram IV push. So again, we talked about this during our, in the first video where we said we want to start CPR. If it's a shockable reading, we want to shock. We continue CPR for another 2 minutes. If it's a shockable reading, we also want to shock. That's when we want to give our epinephrine after the second shock. So again, we want to do CPR, we want to shock. If it's a shockable reading like we have here in our PVT, we want to shock a second time before we give epinephrine. We also talked about this in the last video, and we said after the third shock, we can try giving amiodarone, or we can give lidocaine. So again, remember with your amiodarone, you want to give 300 milligram, and if we need to repeat our amiodarone, we want to give 150 milligram. And just to mention, with adenosine, if we want to use adenosine to cardiovert or convert our patient, we want to give 12 milligram first. And if we need to repeat it, we want to give 6 milligram. So I forgot to mention that. So you want to take note of that, although it's in our previous video. So you need to go back and watch some of those videos. Okay, so I think this is just straightforward because I want us to finish the slides, call it a day, and then the next class would be to go into the full course content of the ECG reading analysis and interpretation. So again, we talked about ventricular tachycardia. Well, I don't remember if it's okay. So that's your ventricular tachycardia here. What do you notice here? You notice how they have one shape. All of the rhythms, they have one shape. So we can also call this, we call this a ventricular tachycardia. We can also call it a monomorphic ventricular tachycardia. Mono means one. Morphic means shape. So it has one shape. So we can call this a monomorphic ventricular tachycardia. Well, that's if you want to show off. Yeah, I know ECG. So this is a ventricular tachycardia. If you call it a tachycardia, you're right. If you call it a ventricular tachycardia, you're also right. If you call it a monomorphic ventricular tachycardia, you are also right. If you call it a pulseless monomorphic ventricular, you are still very right. But again, I just wanted us to draw that distinction there, that this is a monomorphic ventricular tachycardia, just because it has one shape. And if we fall back to this, what do you notice? We see multiple shapes here. This would be a polymorphic ventricular tachycardia. I don't know how the French call it, but they call it a torsades de pointe. I don't know if I'm pronouncing it right, which means like a twisting of the points. So this is a torsades de pointe. It's actually a polymorphic ventricular tachycardia. So you see all these curious complexes that change in size and shape in a characteristics twisting pattern. And what causes torsades de pointe or this polymorphic ventricular tachycardia? It's usually as a result of electrolyte imbalance. Which of the electrolytes? Your magnesium. So you're going to always see torsades de pointe or polymorphic ventricular tachycardia inclines with hypomagnesemia. Although some other medications can cause this, where you see prolonged QT intervals, but we're not going to go into that. But I just wanted to take note of that. Even how I remember this is that if I write a straight line here and draw another one here and draw another one here and bring it down here, it's almost like an M, which reminds me of magnesium. So whenever I see a twisting around the points or a polymorphic VT, that reminds me of magnesium or hypomagnesemia. And the first line treatment, well, obviously, if your client is having low magnesium, you want to give him IV magnesium. Again, if the client is on any medication that is causing QT prolongation, you know, when the QT intervals become prolonged. So we'll talk about the QT intervals in the next class. But when you begin to see those prolonged QT intervals, it could be as a result of the client being on certain medications. We want to stop those. So again, that could help to reverse this. So at some point, you might need to defibrillate a client in towards the point or who has a polymorphic ventricular tachycardia. So option 3 is going to be my correct answer. We already talked about adenosine. We said we're going to use adenosine to treat our supraventricular tachycardia. So you can use it in this client. It will not be that effective. Option 2 is a vasopressor, and it's used to treat symptomatic hypotension. So we're not going to use dopamine. And again, remember, with vasopressors, just like their names sound, they are pressing the vessels. But if there's nothing in the vessels to press, then your drug will not work as it should, because it's supposed to be pressing the vessels which contain your blood or contain fluids. But if there's nothing there, there will be nothing to press. So again, remember, fluids before pressors. That's one way I remember it. Fluid before pressor. So if my client is maybe in symptomatic hypotension, I'm not just going to give dopamine. I want to be sure that there's good circulatory volume. I'm going to rather put an IV line, start this client on normal saline before I give my vasopressors. Because if there's nothing in the tank, then there's nothing your dopamine would press. So always remember fluids before pressors. So we said magnesium would be our correct answer. We want to give our olols. Olols, what does olol remind you of? Your beta blockers. And we use that for rate controls, especially with tachyarrhythmias. But again, this is not going to help in this client. So for magnesium is going to be your correct option. The nurse is caring for a client who was just resuscitated following an out-of-hospital cardiac arrest. The client does not follow commands and remains comatose. So again, we've had ROCs. So what's ROCs again? Return of spontaneous circulation. So you've resuscitated a patient and then the heart starts to beat and all of that. So we call that state ROCs, which is return of spontaneous circulation. So now the client is not able to follow command and he remains comatose. They're asking us what intervention does the nurse anticipate being added to the client's plan of care. So again, I'm going to ask you to go back after the class and review the post-cardiac arrest care algorithm. But I'm just going to highlight a few points you must know for the Nclex in relation to the post-cardiac arrest care period. One of them would be we want to maintain the systolic blood pressure above 90 meters of mercury. You want to know this for the Nclex. You've successfully resuscitated your patient. We want to check those vitals. We want to check his SpO2. We want to check his blood pressure. We want the systolic blood pressure. So the SBP, systolic blood pressure, to be above 90 millimeters of mercury. We also want the SpO2 to be between, I can't remember exactly, but I think it should be between 94 to 98%. We want the SpO2 to be within those ranges, at least up to 98%. What else? We want our MAP, your mean arterial pressure, to be above 65. So again, I want you to go back after the class and look out for how you can figure out your MAP. So again, we want it to be above 65. So again, I know your textbook might have said 70, but don't mind our different variations. The Nclex will take that into cognizance when they are setting their questions. So again, how do you determine the MAP? Because the Nclex may tell you this patient came in with a blood pressure of 120/80, and they're asking you what you want to do next. Remember, the mean arterial pressure gives you an indication of how well your internal organs, how well the organs are perfusing. That's why you want to know what your MAP values are. In these new monitors that come these days, you can actually see the MAP on the screen. It does the whole calculation for you. But again, they may ask you what you should do. So if you're able to identify, I can't remember the exact calculation, but some textbooks we say I'm not sure, but again, I see systolic blood pressure plus 2 times that diastolic blood pressure divided by 3. But you want to confirm that. I'm not exactly sure. I can't remember off the top of my head now. But again, you want to know how you can calculate your mean arterial pressure in your patient. But however the case is, we want it to be above 65 millimeters of mercury. You also want to what else is there with our post-cardiac arrest care period? So we've talked about the SpO2, we've talked about the systolic blood pressure, we've talked about the MAP. We also want our end-tidal CO2, your EtCO2, to be between 35 and 45. So you want your end-tidal CO2 to be between 35 and 45. So again, you are intubating your patient. We talked about end-tidal CO2. So please go back in the last video and review end-tidal CO2. But that's where we want the ranges to be. Again, we want to carry out a 12-lead ECG. We haven't really, okay, I think we've talked about it in the first class where we talked about ST segment elevation. So again, we want to do a 12-lead ECG. And what are we looking out for? We're looking out for ST segment elevation because that can tell you if your client may be in a cardiac arrest as a result of a myocardial infarction. And we said we want to treat that by carrying out PCI, which is percutaneous coronary intervention. And finally, you want to assess the patient and see if it's able to follow command. So you want to tell the patient, okay, can you move your hand? Can you wriggle your toes? You want to look at the patient, assess and see if it's comatose. Because if it's comatose, then we want to initiate targeted temperature management. And with targeted temperature management, we want to keep this patient at between 32 to 36 degrees for at least 24 hours. So we want to keep him between 32 to 36 degrees for at least 24 hours. So please, if you are writing the Nclex for this period, you need to know this up until 2025 because there's been a review in the resuscitation guidelines and they're going to be taking out this targeted temperature management. So until when that is done, we are still advised to stick with these values. But from the AHA guidelines, which will be released in 2025, they would be taking out this targeted temperature management reference, even the aspirin reference we talked about earlier and all of that. So, but again, if you're still writing before 2025, you still need to know this, that if your patient is not able to follow command, if the patient remains comatose, you want to initiate targeted temperature management. So because of time, I'm just going to go ahead and select our correct answer. So let me see. So it's too early to carry out do not resuscitate. We don't even have any information on the stem of the question that tells us this client has requested not to be resuscitated. So option 1 would be wrong. Option 2, obtaining equipment and cold fields for induction of therapeutic hypothermia. Okay, so again, this has been changed to targeted temperature management. You won't see it as therapeutic hypothermia on the Nclex. So it's actually called targeted temperature management. Placing a small bore nasogastric feeding tube for enteral feeding. Again, option 3 will not be my correct answer because these clients are generally kept neoper-oral during targeted temperature management, and afterwards, when we need to rewarm them, they are also kept neoper-oral. So feeding tube, we may use it subsequently, but not at this point. And option 4, passive range of motion exercises to prevent contraction. This would not be immediate priority. So option 2 would be our correct answer. Okay, the nurse observed a client, a nursing student performing chest compressions on an adult client, which technique indicates that the student understands how to provide high quality chest compressions during CPR. We already talked about this where we said we want our compression depth to be between 2 inches or 5 cm. So you want to remember this with adults, 2 inches or 5 cm. We don't want to pause after each set of 15 compressions to allow for 2 rescue breaths. Again, if I ask, where are we supposed to pause after 15 compressions to give breaths? When we are carrying out infant resuscitation. So you want to know the difference between your adult resuscitation when we're carrying out infant resuscitation, and not just infant resuscitation. So remember, with infant resuscitation, if it's one rescuer, you're going to carry out 30 compressions, and you're going to give 2 breaths for every 30 compressions. But if you have 2 rescuers, then we're going to change to the 2-thumb encycling technique, where you're going to be carrying out 15 compressions, and the second rescuer is going to be given 2 breaths. So option 2 would be wrong. Placing the heels of the hand on the upper half. So again, remember we talked about this. We said you want the heels of your hands to be on the lower half of the sternum. Option 3 is going to be wrong. How about option 4? It's also going to be wrong. Remember we talked about these numbers where we said we want the compression rate to be between 100 to 120. So those are those numbers. Again, you can see what I mentioned earlier. These questions revolve around each other. So if you're able to understand those core basics, then you should be able to apply it with whichever question you have on the Nclex. So good enough, we have 3 more slides before we call it a day. So the nurse is preparing to defibrillate a client who suddenly, can't see what's there, due to ventricular fibrillation. Which steps are essential prior to delivering shock? Okay, so I assume this client is going to ventricular fibrillation, and we want to use our AED or our manual defibrillators, and they are asking what are the steps to perform defibrillation. So I'm supposed to arrange this in correct steps. But again, I thought I mentioned this earlier, that the first thing you want to do when you get your defibrillator is to turn it on. So we want to turn it on. That would be the first step when you are using your defibrillator. And when you turn it on, the aid is going to tell you, place the pads on the patient's chest. Place the pads on the patient's chest. So this would be, for me, this would be my first step. So let me just number this number 1. And then once the pads are placed, the aid is going to tell you, it's analyzing the patient's heart rhythm. It's going to tell you no one should touch the patient. And if it detects a shockable rhythm, the aid is going to charge. And once it's fully charged, well, again, let me just add this. With the new guidelines, normally before, when we are charging our manual defibrillators, we don't normally, everybody stays clear why the defibrillator is charging. But with the new guidelines, there's been new introductions. One of them would be to hover. So in case you see this on the Nclex, you are advised to hover. So normally when you do 30 compressions, you're supposed to stay clear and wait till they've given 2 breaths before you do another 30. But now the AHA is saying, just place your hands over the chest. Just hover over the chest. Why are they advocating this? So that you don't waste so much time coming into position again, because we want to limit interruptions in chest compressions to at least 10 seconds. So the AHA is advocating or advising that you hover, whoever is compressing should hover over the chest. Another guideline you need to know with CPR would be when the AED is, when the manual defibrillator or the AED is charging, because it's going to take a while to fully charge, you want to carry out chest compressions while the AED is charging. It may not get up to 30, but at least you're able to throw in a couple of compressions while the AED is charging. Also, if you have a team that is fully trained, the AHA is actually advising that you pre-charge the monitor, you pre-charge your defibrillator. So we say we're going to do compressions for 2 minutes. But what they are saying is, once it's 15 seconds to shock the patients, once you have 15 seconds to the end of the 2-minute cycle, whoever is in charge of the manual defibrillator should charge the machine. If you're not shocking, just pre-charge the machine. But once we get to 2 minutes mark and we are stopping compressions, the manual defibrillator is already fully charged, and we can just analyze the rhythm, shock the patient. So you don't have to waste time charging for long. So you can remember this 15 seconds to go. You want to pre-charge the defibrillator so that once we get to the 2 minutes mark, we just analyze and shock the patient. Another thing you can do once it's 15 seconds to go, especially for the advanced cardiac life support providers, is that if it's 15 seconds to go, we want to have somebody feeling for a femoral pulse, because when you are doing CPR, there's going to be a femoral pulse because you are beating this patient's chest, you are beating this patient's heart for him. So we're going to be feeling a femoral pulse. And once it's at 2 minutes mark, everybody's going to stay clear and you are going to stay put and see whether after they stop chest compression, are you still feeling a pulse? Because that would help to determine if there's a return of the patient's pulse. So that's something else we can do 15 seconds towards the end of the 2 minutes mark. So again, whoever is in charge of timing is going to tell us it's 15 seconds to go. At that point, the defibrillator is being recharged and somebody's feeling for a femoral pulse. Okay, so I just thought I should add that in there. So again, we've applied the defibrillator pads. So again, call out, okay, so ensure that, so we need to select all that apply. So we want to apply the pads, so that would be correct. Again, before we shock, we want to call out and ensure that everybody is clear. That would also be correct if we want to shock. Continue chest compressions until ready to deliver shock. Like I mentioned, this is also advocated. Ensure adequate IV sedation has been given. We don't need to sedate our patient to shock, except we are carrying out cardioversion. But again, remember I mentioned this earlier, even if we want to sedate, if the patient is unstable, you don't want to delay cardioversion because of sedation. So again, option 4 will be wrong. Finally, ensure the synchronization button is on. We only want to press the sync button if we're carrying out synchronized cardioversion. So option 1, 2, and 3 will be our correct answer. The nurse is teaching a client with this rhythm about the need to begin long-term anticoagulant therapy. Which explanation should the nurse use to best describe the reasoning for this therapy? Okay. This is what we already talked about. We said if your client is in atrial fibrillation, because by looking at this, I see those fibrillatory waves. Again, if you're not sure what we are talking about, go back and look at the previous videos. So I see those fibrillatory waves here, and I see my narrow QRS complex. I see those fibrillatory waves here, and again, I see my narrow QRS complex. So rather than see our P waves here, what are we seeing? We are seeing fibrillatory waves, and that tells me that the atria is fibrillating. So this would be our atrial fibrillation. And we said with atrial fibrillation, the heart is quivering, the atrias are quivering. And because of that, blood is sluggishly moving through the atrias. And what's going to happen? As the atrias are quivering, blood is sluggishly moving, the client is at a very high risk for throwing a blood clot. So remember on the Nclex, whenever I see atrial fibrillation, I'm already thinking, what's the most severe complication that can arise from atrial fibrillation? And that would be development of a thrombus or a blood clot, because the blood is stagnating in those quivering atrias. Again, what happens if you have a blood clot? The clot can move to the lungs. What will happen to the client? It develops a pulmonary thrombus. It can move to the brain. What would happen? It will become a cerebral emboli. So again, you want to take note of this. So that's why this client has to be on anticoagulant. So if you don't remember anything from today's lecture, just remember this, that for clients with atrial fibrillation, we want to place them on anticoagulant because they are at a very high risk of throwing a blood clot. So I'm not going to waste time here because of time. Option 4 would be our correct answer, because the atrias are quivering, blood flows sluggishly through them, and clots can form along the heart walls, which would then loosen and travel to the lungs or your brain. So option 4 would be our correct answer. Now, last but not the least, before we call it a day, the nurse reviewing the ECG reading strip of a client with a history of a myocardial infarction notes that the PR intervals are 0.16 seconds. The nurse should arrive at which interpretation of this assessment data? Okay, so so this is our P wave, and this is our QRS complex. From the beginning of our P wave to the beginning of our PR interval, our QRS complex is what is referred to as your PR interval. So this is our PR interval. From the beginning of the P wave to the beginning of the QRS complex, that's our PR interval. Even though it would take a whole lot of time for me to try to explain how we're going to arrive at this, but well, I think we'll talk about this in a subsequent class. But what I want you to remember is that our PR interval should be between 0.12 to 0.2 seconds. So you want to remember that the PR interval is between 0.12 to 0.2 seconds. On the live class, on the core content class, I'll break it down on how we arrived at all of these numbers. You understand it a whole lot better, but you can just memorize this. That's even though you don't need to memorize it when we attend the main class, but just know that our PR interval should be drawn over not more than 5 small boxes or 0.2 seconds. So just note this. So this would be our range. It should be drawn over 3 to 5 small boxes. So you can either remember it in terms of time, or you can remember it in terms of small boxes. So 3 small boxes will give us 0.12 seconds. 5 small boxes will give us 0.2 seconds. So just know that our PR interval would be between 3 to 5 small boxes, or it should be between 0.12 to 0.2 seconds. So again, we have 0.16 seconds. So that tells me this is a normal finding. For those who probably didn't get the explanation, you don't need to worry about it. During the live class, we'll take it, we'll break it down from the ECG, from the electrophysiology of the heart down to the ECG graph paper, and then to identifying those redeems we need to know for the Nclex. So at this point, I'd like to say thank you for joining. Because of time, it's been a long day for me. I'm going to ask if you have any questions, please, let's take it to the Telegram group or the WhatsApp group, and I'm going to be online to respond to any questions you have. At this point, I'd like to say thank you, everybody, for joining, and do have a good night rest. Thank you very much.